Hello, and welcome to today's Lunch and Learn, Peripheral Arterial Disease. It's in your arteries. It's your arteries talking. I'm Dr. Steve Reinches, the President and CEO of North Kansas City Hospital and Meritas Health. Thank you for joining us. Also called PAD, this often underdiagnosed and common circulatory condition affects more than 8.5 million people in the United States. With PAD, the arteries in your legs become narrowed or clogged with fatty deposits or plaque. The narrowed or blocked arteries can restrict flow to your arms and legs, which can cause difficulty with walking. Peripheral arterial disease also can lead to stroke and heart attack. In addition to knowing your risks, detection is vital if you think you have symptoms. At North Kansas City Hospital, we offer screenings to diagnose and determine the severity so you can receive the appropriate care. We're fortunate to have some of the best cardiologists in the city on our staff, and I'm excited to have one of them talk with us today. Dr. Justin Maxfield is a cardiologist with Meritas Health Cardiology. He will talk about the risk factors, the symptoms, treatments, and how to prevent your risk for a heart attack, a stroke, or peripheral arterial disease. Dr. Maxfield is board certified in cardiovascular disease, echocardiography, and internal medicine. He received his medical degree from the University of Kansas and completed his internal medicine residency at Washington University Barnes-Jewish Hospital in St. Louis. He further did a general interventional cardiology fellowship at the Texas Heart Institute and St. Luke's Hospital in Houston, Texas. Please join me in welcoming Dr. Maxfield.
All right, thank you, Dr. Righteous, for that introduction. As he mentioned, my wife and 2 kids and I moved up from Houston after I completed my general and interventional training in Houston, Texas at the Texas Heart Institute. We joined Meritas Cardiology in August of 2021. So I've been here about 6 months now, and we love our time in the Northland and love being here. Prior to that, I trained at Washington University in St. Louis for internal medicine, and then completed my medical training here in Kansas City, actually at the University of Kansas School of Medicine. As Dr. Righteous mentioned, we're here to talk about peripheral artery disease, and a few of the objectives I want to accomplish today are to describe what PAD is, or peripheral artery disease. What are some of the symptoms that might be consistent with peripheral artery disease, and what you should be aware of to make you think that you might have it. We'll talk about why people develop PAD and some of the risk factors involved in that, as well as how you will know if you have PAD. And then if you're diagnosed with PAD, I want to go over some of the treatment options for that. So we'll start with what is PAD. And before we dive into the specifics of PAD, I wanted to talk briefly about atherosclerosis. Many of you have probably heard of atherosclerosis. Essentially, that's the buildup of plaque within the arterial wall that can cause the artery to become stiff, narrowed, or blocked completely. As you can imagine, as a plaque builds up in the arterial wall, blood flow can slow, and that ultimately can lead to symptoms in patients. In this picture on the right, I hope you can appreciate, this is the outer lining of the arterial wall. You'll see this yellow material, which is plaque. It's made up of lipid molecules and cholesterol, as well as some inflammatory cells. And then hopefully you can see this tiny red line on the inside of this artery, and that's the inner lining of the arterial wall. And so that plaque is actually sandwiched in between the wall of the artery, not actually in the lumen of the artery. Now, this process can occur in multiple blood vessels within the body. It can occur in the carotid arteries, which bring blood flow to the brain and can increase your risk of strokes. It can occur in the coronary arteries, and we call that coronary artery disease, and increase your risk of heart failure and heart attacks. And then it can occur in the arms or the legs, and we call that peripheral artery disease, which is what we're going to talk about today. So what is PAD? PAD is the buildup of that plaque in the arms and more often the legs. Why is it important? Well, one, as you can imagine, as that plaque builds up and intrudes into the lumen of that artery, blood flow can slow and patients can develop symptoms. In addition, PAD is a red flag for the increased risk of heart attacks and strokes. As I mentioned, that atherosclerosis can occur both in the legs and the arms, but also in the heart and in the brain. And this is a very common condition, unfortunately, and often underdiagnosed. It's estimated around 8.5 million people in the United States have peripheral artery disease. So what are the symptoms you need to be aware of to make you think that you might have PAD? The symptom we often describe is claudication, and what that means is the burning or cramping sensation that can occur in the legs, usually induced by exercise or walking and relieved with rest. Now, symptoms aren't always typical in patients with PAD. Occasionally, patients may describe tiredness or heaviness in the legs with walking or exercising that improves with rest. Oftentimes, patients can't walk very far. And if the PAD becomes severe enough, patients will often have skin breakdown, have ulcers that don't heal well, and that is severe PAD and severe restriction of blood flow in the legs. The unfortunate part of PAD is that over 40% of patients often don't have any symptoms at all, which makes it tough to diagnose. Now, we know that not all patients with PAD or with leg pain have PAD. Pain that would not be consistent with restriction of blood flow in the legs would be pain that may continue while standing still, may be relieved with walking or changing in position. There's many things that obviously can cause pain in the legs, whether it be a neuropathy or spinal stenosis, myopathies, or osteoarthritis. And your doctor should ask you pertinent questions regarding what makes your symptoms better, what makes them worse, to help diagnose this condition. So let's talk next about why people develop peripheral artery disease and some of the risk factors associated with that. The first risk factor that we need to be aware of is unfortunately one we can't do a lot about, and that's age. With each decade in life, our risk for PAD doubles. The most common or most correlated risk factor with PAD is smoking. And diabetes actually increases your risk of PAD up to 4 times. And the combination of smoking and diabetes dramatically increases your risk for developing PAD, as well as heart attacks and strokes. 9 out of 10 patients with PAD have hypertension. We talked about that process of atherosclerosis causing stiffening of the arteries in the body, which can ultimately increase your blood pressure. And then we also talked about that plaque buildup, and that plaque is filled with lipid molecules and cholesterol, most specifically LDL cholesterol particles. And so the higher that cholesterol is in your body, the increased risk you have. So how do you know if you have PAD? Well, first of all, your physician will likely ask you many of the questions regarding the pain you have. Does the pain get better with exertion? Does it get worse with exercise? Does it get better when standing still? Do certain positions, whether leaning over a shopping cart, make the pain better or worse? Once they ask the pertinent questions, they'll often do a physical exam, usually involved in checking the pulses in your legs and your feet and determine if they're weak or strong. And then if there's any suspicion based on your history physical exam, then oftentimes we'll order what's called an ABI or ankle brachial index. And that's a simple test where we check the blood pressure both in your arm as well as your ankle, and we compare the two. Normally, your blood pressure should be the same or slightly higher in the ankles compared to the brachial artery. If that blood pressure is decreased at all, then we've got to be suspicious that there's a blockage there that contributing to that decrease in blood pressure. Unfortunately, it's not always that easy, and sometimes patients with peripheral artery disease have normal ankle brachial index, but may have the typical symptoms or may have weakened pulses in the legs. And that situation will oftentimes put patients on a treadmill and exercise them for a brief period of time, and that will often drop the blood pressure in the ankles, which would be abnormal and show us that PAD is present. If the ankle brachial index is abnormal, the next test is usually some sort of imaging. Oftentimes, we'll either get a CTA or an MRA, which will allow us to directly visualize those blood vessels. One, this is less invasive, but also can provide some valuable information in case we need to intervene in the cath lab. The gold standard for diagnosing PAD is catheter-based angiography. This is a little more invasive than a CT or an MRI, but the advantage to this is not only can we diagnose PAD, we can also provide therapy at the same time. You'll see in this picture to the left, labeled A, the top of the screen is the aorta. And what we do is we put an IV in the artery and a catheter, which is a hollow tube, up into the aorta. And we put contrast in the aorta, and the blood travels from the top of the screen down to the bottom of the screen. And we visualize how well that blood travels and if there's any restrictions to the blood travel. You'll see here on the left, this aorta splits into two, and each one of these blood vessels here go down to each one of the legs. This blood vessel on the left is smooth and looks as though the blood is traveling well. Unfortunately, this blood vessel on the right, it's smooth at first, but then it starts to pinch down. You can see where I'm pointing right now. There's a pinch, which is a plaque restricting blood flow to the leg, and oftentimes would cause symptoms. I'll give another example of this on this next screen. This is the femur, so the thigh bone. And this is a blood vessel here. And you'll see it may be smooth up here, but you'll start to see some areas where it's narrowed, and that's a plaque, and actually multiple plaques along this blood vessel, likely causing this patient significant symptoms. So what is the treatment for PAD? Say you were diagnosed with this. Oftentimes treatment is focused around two goals. One, we want to reduce the amount of symptoms that a patient is experiencing. But two, we mentioned that patients with PAD have an increased risk of heart attacks and strokes. And we want to reduce that risk as much as possible. Quitting smoking accomplishes both of those goals. Not only has quitting smoking shown to increase the symptom-free walking distance of patients with PAD by over 40%, it also, in patients that were undergoing surgery for their PAD, increased their 3-year survival over 60% compared to those patients that were not able to quit smoking. Exercise is another key treatment for improving symptoms in patients with PAD. Specifically, a structured exercise or a supervised exercise program, one that we offer within our cardiac rehab here at Meritas, looks something like what is described over here on the right. Usually there will be 3 to 4 sessions a week, approximately 30 to 45 minutes long. And we exercise either on a treadmill or a bicycle at an intensity where patients will develop symptoms and then rest for a period of time until those symptoms in their legs gets better, and then continue to exercise. This is shown to dramatically improve patients' ability to walk without symptoms. Over 180% increase in walking distance without symptoms in one recent study. We have several medications that can help accomplish either the goal of reducing symptoms or reducing your risk of heart attacks and strokes. Silestazol is one we use quite frequently. Not everyone, depending on different medical conditions, can be on silestazol, and your physician will be able to navigate that with you. But it's a medication that we take twice a day. Its mechanism of action is to dilate blood vessels, and as you can imagine, dilating the blood vessels can improve blood flow to the legs and diminish those symptoms. When they studied this medication, patients were able to walk over 60% further without developing symptoms while on this medication. Another key treatment is cholesterol-lowering therapy, usually statins in this situation. We talked about high cholesterol being a key risk factor in developing PAD. Well, it's also a key opportunity for treatment as well. Not only lowering your cholesterol can keep that plaque that may be in your arms or legs from getting bigger and restricting more blood flow, it can also reduce the risk of heart attacks and strokes. Patients that were able to take a cholesterol medication for 5 years were able to reduce their risk of heart attacks by 24% and reduce their risk of stroke by over 27%. We talked about how 9 out of 10 patients with PAD have hypertension. And That hypertension puts more stress on the blood vessels in the brain and the heart. We know that reducing that blood pressure with the goal of getting it less than 130/80 consistently can dramatically reduce your risk of heart attacks by 22%. The final medication I want to talk about today is blood thinners. And usually in PAD, we either use low dose baby aspirin or a medication called Plavix or clopidogrel. And the mechanism of action is to prevent the blood clots that can cause both heart attacks and strokes. Now, anytime anyone's on a blood thinner, it's always risk versus benefit. We know that blood thinners increase risk of bleeding in some patients, but they also reduce the risk of heart attacks and strokes. And further discussions should be had with your physician based on your risk. So we talked about the medical management of PAD. I want to talk briefly about the minimally invasive management of PAD. Oftentimes, if we see a blockage or a narrowing, as I showed in previous pictures, what we'll try to do is put a wire, a very small wire, usually less than 0.035 inches or less across that lesion or that stenosis, that blockage and plaque. And then over that wire, we're able to put a balloon, which can have drugs on it that can deliver to that plaque and keep it from reaccumulating, or sometimes a stent. And as we blow up that balloon and that stent, it pushes the arterial wall open and keeps it open, which can improve blood flow. I'll show you some examples of this in the next few slides. This picture labeled B over here on the right is similar to the previous picture I showed you. At the top of the screen, you have the aorta, and blood flow starts from the top of the screen and will travel down through the legs, or through these arteries to the legs. Over here on the left, picture labeled A, you'll notice the aorta is at the top and that only one blood vessel is traveling down. And that's because this blood vessel on the left here is 100% occluded. You can kind of see where it should be based on this dotted line. You will see that the blood vessel shows back up at the bottom of the screen. And it does that because you'll notice some small little blood vessels kind of twisting through here. And those are what we call collateral blood vessels that your body develops, kind of natural bypasses that allow some blood flow to get to the leg, but that wouldn't be enough blood flow to keep symptoms away. And so often in this situation, some further intervention needs to be done. And what we would do is we would put a wire across this blockage, kind of along that dotted line. And once we're able to get it across that blockage, we advance a balloon and balloon open that artery, and then ultimately stent open that artery, which is what you'll see in figure B, where the blood flow is now traveling down the native artery to the leg, and patient would have dramatic improvement in their symptoms. You'll also notice that many of these collateral arteries that you see in picture A are now gone because they're no longer needed and blood flow is traveling down that artery as intended. Here's another example of some of the catheter-based therapies that we offer. I want you to focus on picture A first. There's an artery that you'll see on the top left there that completely stops kind of in the mid-screen there. You'll notice it shows back up kind of a ghost of an artery at the bottom of the screen. And again, this is 100% blocked up here, but there are collateral arteries providing some blood flow to the rest of the leg. What happens again is we put a tiny little wire within that vessel. We balloon it open, which you can see in B, and there's blood flow going through this artery now, but it's still some areas of pinched off blood flow that is not adequate for reducing symptoms. And in this situation, a patient required stenting, and now you can see blood flow flowing smoothly down through that artery. And once again, the collateral arteries that you see in figure A are now gone in figure C. So in summary, just want to let everyone know how underdiagnosed this condition is and how frequently it is asymptomatic. Yet, even though it's asymptomatic, the risks are still there of increased risk of heart attacks and strokes. And now we know the risk factors and how to modify them. And there's obviously multiple tools, whether it's medications or minimally invasive procedures, where we can diagnose and also treat PAD. And just to let you know, we at Meritas Health Cardiology specialize in a number of things, including peripheral artery disease. We have excellent physicians who can help with coronary artery disease, heart failure, abnormal heart valves, or even abnormal heart rhythms. So please give us a call with any questions or concerns and come see us. Our number is 816-221-6750. And I'll open it up to any questions.
Well, thank you very much, Dr. Maxfield. That was fascinating, and I love those examples that you showed. And in fact, I was going to, ask a little bit about the anatomy there. But could you tell the audience what complications may occur if peripheral arterial disease is not treated?
Certainly. If it's not treated, the ultimate that plaque is going to get bigger. The blood flow becomes more restricted, and then ultimately it becomes severe PAD, which I described as non-healing ulcers, wounds, ultimately gangrene, and very rarely patients require amputation for that.
Mm-hmm. What you talked about diabetes as a condition, and you talked about high cholesterol as a condition that can cause peripheral arterial disease. Can you give the audience an idea of what the cholesterol numbers would be that would predispose someone to peripheral arterial disease?
Certainly. I think a lot goes into that. Ultimately, if you're diagnosed with peripheral artery disease, we know that if we can get your cholesterol, your LDL cholesterol, less than 70 and ideally less than 55, it dramatically reduces your risk of heart attacks and strokes. Now, a number of things obviously contribute to building up plaque. Certainly the higher the LDL, and certainly anything above 190 would be very concerning for the buildup of plaque in the legs and the arms, as well as the heart and the brain. As far as blood sugars, our goals are to get your hemoglobin A1C less than 7.0. We know anything above that dramatically increases the risk of plaques building up.
It's fascinating. So when you get peripheral arterial disease in the legs, does that mean that you have peripheral arterial disease in the coronary arteries or in the brain? Is peripheral arterial disease in one location mean that you have it in all locations?
Yeah, great question. And the concern is if you've got it in your legs, that most likely you've developed some plaques within the coronary arteries as well as the cerebral arteries, which is where the increased risk of heart attacks and strokes come from. And so if you do have peripheral artery disease, we have to be aggressive and assume that there are some plaques within the coronaries, as the arteries around the heart, as well as the arteries in the brain.
So if I come to the doctor and I have cramping in my legs with walking and he diagnosed that condition called claudication, will that doctor also look at my heart and look at the blood vessels that go to my brain?
Absolutely. They'll at least assess your risk for those things and be aggressive about medications and be aggressive about reducing your risk, such as reducing your cholesterol to those numbers less than 70 or reducing your hemoglobin A1C less than 7.0 and reducing your blood pressure and keeping it less than 130/80. That way that we can reduce the risk of any of those plaques that may be in the heart or the brain from causing any problems in the future.
So if I went to a cardiologist and I was worried that I had peripheral arterial disease or PAD, what questions should I be prepared to answer during my cardiology visit?
Yeah, I think number one, being able to describe the symptoms and understanding what they feel like and telling your physician what makes them worse, what makes them better. When do you notice them? Is there a position that maybe makes the pain better or worse, are very helpful. In addition to that, if you've had a history of heart attacks or strokes or family history, are going to be very important. And also, if you've had any history of wounds that you notice take a lot longer to heal in your feet or your legs, that would be very important as well.
So if I'm diagnosed with peripheral arterial disease, how often do you see the patients back and how long do you follow them? Is it a condition where you get it treated and you don't have to go to the doctor anymore? Or is it a situation that once you have the diagnosis of peripheral arterial disease, do you have regular scheduled visits with your cardiologist?
Usually, especially early on, until symptoms and risk can be controlled as much as possible, you're going to see your cardiologist pretty frequently, within once every few months. Once those symptoms are controlled and you're feeling better and the risk factors are controlled, usually we can space out the visit further apart than every few months.
Well, I think that this has really been fascinating, and we know with the aging of the population that peripheral arterial disease is going to become more prominent. So thank you for the education today. And I want to thank the audience for joining us today. We hope Dr. Maxfield's presentation was both informative and helpful. Please join us Friday, March 25th for our next Lunch and Learn presentation, Men's Health, Stay in the Game, with Meritas Health, North Kansas City internal medicine physician, Dr. Matt Strasser. Thank you very much and have a good afternoon.